So much, Anthony, for the introduction and the invitation to join today. I'm very glad to have this opportunity to share with you all some of my work on target trial emulations. And this is one of my main areas of research interest, as Anthony mentioned, because it deals with what I think is an exciting question, and that is how we can best use data from large healthcare databases like electronic health records to inform health decision making. And so a large part of my work involves developing and applying tools to do this related to target trial emulations under different study designs. And so that's what I'm going to be talking about today, how we can take the target trial approach, which has been applied under cohort designs, and extend it to case control designs to reduce bias also in those analyses. And so my goal is going to be to show you not just how to do this, but also why it matters. And so this is going to be through some practical examples. First, just to make sure we're all on the same page. So what is this target trial that we want to emulate? This is the hypothetical randomized trial that would answer our causal question of interest. And so when we're interested in comparative effectiveness research, our first step is going to be to ask a well-defined research question. And so specifying the protocol of the target trial can help with this. And so we'll talk about some of those details next. Our second step is then to answer the question. So in an ideal world, we would be able to answer all of these causal questions by conducting a well-designed randomized trial. But sometimes we will not be able to do this because a trial would be unethical or impractical. In those cases, the next best thing that we can do to generate some evidence is to use observational data to explicitly emulate the target trial. So as part of this first step, when we specify the protocol of the target trial, we need to cover all of the same components that appear in the protocol of any randomized trial. And so these will include the eligibility criteria, which will define our population of interest, the treatment strategies that we're interested in comparing, the treatment assignment procedures, follow-up period, outcomes of interest, causal contrasts or estimates of interest, and the analysis plan. And so the idea is that specifying the protocol in this way can help us to formulate a well-defined causal question. And if we plan to then answer it using observational data, because again, let's say a trial is not available, but decisions need to be made now, then our observational study needs to explicitly emulate all of these components. That is, it needs to mirror each of these aspects as closely as possible. And so why? Why does this matter? So what are the advantages of conceptualizing a causal analysis of observational data as an attempt to emulate a target trial? Well, there are a number of advantages that have been described previously. You can check out this paper, but a big one is that it can help us to avoid bias. In terms of which biases, it's important to distinguish something here because there's lots of potential biases in observational studies. One bias that we're always going to be concerned about is confounding due to a lack of randomization. And to be clear, there's nothing we can do to eliminate that concern. The best we can do is try to minimize it by carefully measuring and adjusting for confounders. So that's one bias, confounding bias. But then we also have other biases like immortal time bias and selection bias. And those are due to flaws in observational study design. And those biases can also be substantial, of a huge magnitude. We should be very concerned about them. But the good news is that unlike confounding, we can easily prevent those biases. And so those are the ones that I'm referring to when I say that this approach can help us to avoid bias, and that's because it naturally leads to a design and analysis that prevents those issues. And so in doing so, it can also help to resolve discrepancies that may exist between effect estimates from observational studies and randomized trials. And so that brings us to our example of statins and cancer. So this is a topic for which we do have discrepant evidence from observational studies and randomized trials, where first we have some observational studies that have reported cancer risk reductions as large as 50 to 65% among statin users compared with non-users. And some of these are published in top medical journals. And then we have randomized trials that suggest no effect. And so because these estimates from the observational studies are unlikely to be entirely explained by confounding, given that cancer is not an intended effect of statin therapy, we were interested here in exploring the role of observational study design in explaining these discrepancies. And so we did this in this paper shown here that Anthony mentioned by using observational data from electronic health records and doing our analysis two different ways in that data. First, we explicitly emulated a target trial, which gave us effect estimates that were consistent with previous randomized trials. And then we replicated the analytic decisions of the previous observational studies, and we showed that analytic flaws in the form of deviations from inadequate target trial emulation led to the implausible estimates that were previously reported. And so the key point here was, because we did our analysis two different ways using the same observational data, we were able to show that the failure of observational studies in this case can be explained by deviations from basic principles of study design rather than from lack of randomization. And so after we completed this, it got us thinking. Some of these previous observational studies were conducted under a case control design. So could we extend the target trial approach to help inform future case control analyses that are leveraging electronic health records for comparative effectiveness research? And so why should we bother doing this? Why do we care about case control studies? Well, this is an important design where case control studies may have a role to play in causal analyses of healthcare databases, specifically when the goal is to estimate relative risks and high quality information on treatments or confounders is not available for the entire cohort of interest in the database. In those settings, case control studies can let us focus what might be limited resources on collecting this information for a random sample of cases and controls. But because case control data is just an efficient sampling from an underlying cohort, these studies require the same adherence to the target trial framework, and deviation from this framework may lead to severe bias. And so this is important, but how do we do this? So to dive right in, I'd like to share with you a 3-step procedure to emulate a target trial with case control data. This is going to involve first specifying the protocol of the target trial that would have answered our causal question of interest, then defining the observational cohort study that explicitly emulates this target trial, that is, the cohort study that mirrors the target trial as closely as possible. And then lastly, sampling cases and controls from this cohort. And so this is the approach that we recently implemented in an application to statins and colorectal cancer. And so I'm going to walk you through this in the context of that example. We're starting here. Our first step was to specify the protocol of a target trial to estimate the effect of statins on colorectal cancer incidence. And so here is our summary of the protocol of that target trial, where briefly the eligibility criteria included age 30 and up, no history of cancer, no statin contraindication, no statin prescription within the past year, and LDL cholesterol less than 5 millimoles per liter. And baseline here is defined as the first month in which all of these eligibility criteria are met. The treatment strategies to be compared are start any statin therapy at baseline and continue it over follow-up until you develop a contraindication, and do not start statins at baseline or over follow-up until you develop an indication. And so these are dynamic treatment strategies because treatment depends on these evolving conditions. That is, when a patient develops one of these contraindications or indications over follow-up, patients and their clinicians will decide together whether to start, stop, or switch treatment. In the target trial, participants are randomly assigned to a strategy at baseline, and they will be aware of the strategy to which they have been assigned. The outcome of interest is colorectal cancer, and people are followed from baseline until the month of first cancer diagnosis, death, loss to follow-up, 6 years after baseline, or the administrative end of follow-up. We're interested here in the intention to treat effect of being assigned to a given treatment strategy, as well as the per protocol effect of adhering to it. And this would involve a standard ITT analysis and a per protocol analysis in which people are censored if and when they deviate from their assigned treatment strategy. And then we can apply inverse probability weights to adjust for the selection bias that we potentially introduced with this artificial censoring. And so that was step one. And after we specified the protocol of the target trial, our next step was to define the observational cohort study that explicitly emulates it. Specifically for this task, we had access to a large database of linked electronic health records in the UK from primary care, hospitals, and death registries that we accessed through the Caliber resource. And so this database contains information on many different features, some of which are shown here, where I just want to highlight that a key strength of this data resource is the availability of information on potential confounders not available in other large healthcare databases, including claims data. And this includes lab test results and lifestyle factors. And so I said that our goal was to mirror each protocol component of the target trial as closely as possible, just making modifications where we need to accommodate the fact that we're using observational data. For example, here we applied all of the same eligibility criteria to people in the EHR database, plus to assess baseline confounders. We also required that certain lab and lifestyle factors were measured within a certain amount of time before baseline. And this left us with approximately 750,000 people eligible for the analysis. To emulate the treatment strategies, we have prescription records for these individuals. We want to end up with monthly indicators for whether someone is on statins or not. And so to do this, we defined the date of statin initiation as the first date of a prescription, and we calculated discontinuation dates using the daily dose and quantity of pills in the prescription. And we consider treatment to be continuous if there was a gap of less than 30 days between successive prescriptions. To emulate the treatment assignment, we classified people into one of two groups according to the strategy that they were compatible with at baseline. And this is under the important assumption that these groups were exchangeable at baseline, conditional on baseline variables. You can see here that we were able to adjust for a variety of potential confounders that spanned demographics, lifestyle factors, labs, diagnoses, prescriptions, and markers of healthcare utilization. For the statistical analysis, this would proceed as for the target trial with adjustment for those baseline variables in an attempt to emulate randomization. Then we could use pooled logistic regression to estimate intention to treat and per protocol effects via hazard ratios, risk differences or survival differences, and survival curves if you'd like. Something I want to emphasize here at this point is that everything that I'm describing now for the statistical analysis will apply to both a cohort analysis and a case control analysis. Except in the case control analysis, we're not going to be estimating absolute risks. So given that overlap, my plan is to dig into these details first under a cohort design, just as a familiar starting point. And then when we get to the case control design, we'll talk about what we need to do to fit these same models. And so because this is a methods seminar, let's take a look at some models. So these are the models that we'd actually fit in a cohort analysis, starting with the ITT analysis. To estimate hazard ratios here, we could fit a pooled logistic regression model that looks like this. So this model contains a flexible function of time since baseline, which we modeled using linear and quadratic terms, an indicator for assigned treatment strategy, and the baseline confounders. And the odds ratio from this model, that is if we exponentiated beta 1, the coefficient of the assigned treatment strategy indicator, that odds ratio approximates the intention to treat hazard ratio comparing treatment initiation versus no initiation. Then if we want to estimate absolute risks in this cohort analysis, we would fit this same model, except it has an additional product term between treatment and follow-up time. Then we could use the predicted probabilities from this model to estimate each person's probability of colorectal cancer at each time under a given strategy. And then, of course, we can standardize those probabilities to the joint distribution of the baseline covariates. So one comment that I want to make here is you could apply to these models time-varying inverse probability weights to adjust for potential selection bias due to loss to follow-up. And so in our case, that additional adjustment did not influence our point estimates. And so we left that out of our primary analysis just to keep things simple. So this is just to say that in our ITT analysis, we fit unweighted pooled logistic regression models, but you could fit weighted models here that incorporate those censoring weights. For the per protocol analysis, we fit the same models to the data after censoring people who deviate from their assigned treatment strategy. Specifically, we censor people in the initiator group when they stop statins in the absence of a contraindication, and we censor people in the non-initiator group when they start statins in the absence of an indication. And then we apply time-varying inverse probability weights to adjust for pre- and post-baseline prognostic factors that are associated with adherence to the assigned treatment strategy, and also potentially associated with loss to follow-up. But again, that didn't make any difference in our example. So here I just show in the top right corner the weights for treatment adherence. And so when we implemented this analysis in this cohort that we've defined, we found that the effect estimates were near null, as shown here. That is, statins do not appear to influence colorectal cancer incidence over up to 6 years of follow-up. And this is consistent with findings from meta-analyses of randomized trials. So at this point, we've specified the protocol of the target trial. We've defined the observational cohort study that explicitly emulates it. And here I'm showing you the effect estimates from the cohort analysis just to show you that they're near null and consistent with evidence from trials, and because we're going to later compare these with the estimates that we get from a case control analysis. And so that's where we're moving now. So we've arrived here at our last step, which is to take this cohort of eligible individuals that we assembled and sample from it, cases and controls. Here we performed incidence density sampling, where we selected all colorectal cancer cases diagnosed over the study period. So you'll see in this picture a highlighted box around each of these circles, which represents the selection of all case person months. And we also selected random controls on random months. So that's these other highlighted boxes. And so these controls were people who were alive, under follow-up, and free of colorectal cancer at the time of selection. In this case, we picked 1,000 controls per case just to minimize any differences due to random variability when we were then going to compare our effect estimates from the cohort analysis and the case control analysis. But of course, case control studies are typically based on a much smaller number of controls. And so a key point here is that we are sampling from the assembled cohort of eligible individuals. That is, we are sampling from the underlying cohort that explicitly emulates the target trial. And so it's very important that we don't lose sight of that or this underlying time zero, as we'll see when we start considering the analysis of this case control data. So for the analysis of the case control data, as it turns out, this will proceed just as in the cohort analysis. That is, this will require the same models that we discussed and that I include again here. But if we take a close look and we compare the information available at the time of selection alone, that is within each of these highlighted squares, versus the information we need to fit these models, that is not only the treatment strategy and confounders at baseline, but also treatment and confounders over follow-up to estimate the weights, then it becomes clear that we will have to obtain for selected cases and controls their full history of treatment and confounders from baseline through the time of selection. And so this means that we need to figure out for each selected person, what was their treatment status at the underlying baseline in January 1998 and in every month thereafter, up until the month of selection. And we need to know the same for their confounder values. And so with this in mind, how does the analysis work? So to be explicit, we can think about breaking this into steps, starting with the ITT analysis in a case control sample, where we said the first step is to select cases and controls from the assembled cohort of eligible individuals. And so this is where the investigators would obtain, for cases and controls, information on their treatment and confounder values at baseline. And so if you remember, the entire rationale for doing a case control study within an existing healthcare database is that we don't have high quality information on these features. And so we have to go out and get it for a sample of cases and controls. Here I say that we will need to get baseline values at a minimum. That is, if we are making no adjustment for potential selection bias due to loss to follow-up. If we are making that adjustment and therefore need to estimate time-varying inverse probability weights, then instead we need to get information on their full history of treatment and confounders from baseline through the time of selection. And so once we have that information, our next step is just to fit a pooled logistic regression model for the outcome to the selected cases and controls. And so this is the same model that we saw before that we used in the ITT analysis in the full cohort. And we're now just fitting it to the case control sample, where the odds ratio from this model will be an unbiased estimator of the ITT hazard ratio obtained from the full cohort. Again, this is going to be an unweighted model if you're making no adjustment for potential selection bias due to loss to follow-up, and it will be a weighted model if you are. For the per protocol analysis, after we select our cases and controls, we will need to obtain information on their full treatment and confounder history from baseline through the month of selection. And we need this full history because we need to estimate time-varying IP weights related to treatment adherence over time. And so to do this, what we're going to do is fit our weight models to the selected control person months and their history. And then we use the parameter estimates from those models to generate predicted probabilities for all person months, that is, for cases and controls. And then, just like in a cohort analysis, the final weight for each person at each time point is taken as the product of the weights for that person up until that time. And so again, this is why we need treatment and confounder history for the selected cases and controls. Next, we can censor people if and when they deviate from their assigned treatment strategy. And we will know this, we will know when this happens because we have their entire treatment history. And then we can fit a weighted pooled logistic regression model for the outcome to the selected cases and controls. Again, this now this weighted model is the same model that we saw before in the per protocol analysis in the full cohort. And the only new thing here is we need to follow this procedure to get the information we need to fit this weighted model now in the case control sample. And so when we implemented these analyses in our case control sample, we found that, as expected, adequate case control sampling yielded the same estimates as in the cohort analysis, which again were near null. And so this got us thinking, what about those previous case control analyses that reported such extreme estimates? Is there anything in their approach that could help to explain these estimates and this, huge discrepancy that exists between evidence from those observational studies and from the randomized trials? And so just to give you a sense of the magnitude of the estimates from these case control studies, one of them had reported an odds ratio around 0.5 when comparing colorectal cancer cases and controls with respect to their statin use. So long-term use for 5 or more years versus shorter-term use. So that's an estimated odds ratio around 0.5. And this was published in a top medical journal. We wanted to better understand this. And so what we did next was we applied the analytical approach of this previous study to our data. And this was so that we could evaluate how deviations from this target trial approach may lead to bias. And so I'd like to walk you through this, but I want to preface this by saying that for everything that comes next, I don't want to focus on this one particular study because these deviations that I'm going to describe, they can be found in many studies. This is what I think is this is a widespread problem in the case control literature. And so my goal is to just focus on these bigger picture concepts that will be widely applicable. And so to dive right into these, so let's start with the first potential deviation. And this one is related to what is a common feature of case control studies, and that is an interview with the participants. This is again because one of the main motivations for even doing this case control study within an existing database is the investigators may have decided they don't have high enough quality information in the database, so they need to go out and get it. And they can do this, for example, by arranging interviews with the sample of cases and controls that they've selected. And then at the interview, they can go ahead and gather some detailed information on participants' treatment use and their confounder values. And so just to be clear, I think this is great. This is a good thing. We want higher quality data. But when we might run into trouble is when the analysis is restricted to eligible cases and controls who could be interviewed. That is, those who remained alive and under follow-up for a period of time after being selected into the study. And this will be particularly problematic if there is differential loss to follow-up in the two groups over that period. And so in this figure, the boxed eyes represent the interview, which is happening with some lag after selection. And all I'm saying here is that things can happen in this gap between the time of selection and the time of interview. People can die, people can be lost to follow-up, and those patterns may be different in the two groups. And so how does this represent a deviation from the target trial? Of course, this survival requirement does not exist there. Next, we can also run into some trouble in a case control analysis if we classify cases and controls based on their observed duration of treatment after baseline. So let's say treatment use, cumulative treatment use for 5 or more years versus less than 5 years. And so if we compare this with a target trial approach, this does not correspond to an intention to treat analysis, which assigns people to a treatment strategy based on baseline information only. And this does not correspond to a per protocol analysis, which again assigns people to a treatment strategy at baseline based on baseline information only, and then censors them at deviation from the baseline assignment. And so on top of that issue, we can make things even worse if we assess cumulative duration of treatment from baseline through the time of diagnosis, that is selection for cases, but through the time of interview, that is post-selection for controls. That is, if we use a longer period of potential treatment use for controls, baseline to interview, than for cases, baseline to diagnosis. And so do we think this is widely happening in case control studies that involve an interview? I don't know. We can think about how investigators might be sitting down with selected participants. So starting with cases, is it plausible that they're asking them to report their treatment history through the time of diagnosis only? That is the time of selection? Yes, I think that's plausible and that would be appropriate. But when they sit down with selected controls, do you think they're asking them to report their treatment history only up to the random day that they were selected? Hopefully, but I think there's a chance that they're being asked to report their history up until the time of the interview. And so just to be clear, either way, this first decision alone to classify people based on their observed duration of treatment, that alone is problematic, regardless of whether controls are reporting their history through the time of selection or interview. That's just an additional layer of complexity that might be worth consideration. And so what else can go wrong? So this next one here is frighteningly common in case control analyses, and that is adjustment for covariates assessed at the time of the interview. That is values of the covariates at the time of the interview. Or these could be values at the time of selection, and that's still a problem. From a target trial perspective, this would be equivalent to adjusting for variables that were measured either at or after the end of follow-up. And so we know that that will not appropriately adjust for confounding, and this might induce selection bias. And then if we think about what does a correct intention to treat analysis look like, that's going to be adjusting for baseline confounders. What does a correct per protocol analysis look like? That's adjusting for baseline and post-baseline, that is time varying confounders during the follow-up. The last potential issue that I'd like to highlight here is that if traditional case control studies lose sight of this underlying time zero, and they're not sampling from the underlying cohort of eligible people, then they could be including cases and controls who were using treatment before baseline, that is prevalent users. And they could also be using pre-baseline treatment to quantify total duration of use. And so, in a target trial, of course, these people would not be eligible. And we know that including prevalent users at baseline may contribute to selection bias due to a depletion of susceptibles. That is the selection of people who received pre-baseline treatment for some time and remained at risk and under follow-up at baseline. And so those are the 4 deviations from the target trial that I wanted to highlight here. After we identified these, what we did next was we wanted to assess the cumulative impact of these deviations on our effect estimates. And so what we did was we sequentially implemented them in our own case control analysis. So specifically, returning to this first deviation, to implement this, we restricted our case control analysis to people who were alive and under follow-up 3 months after selection. And this was the estimated average lag between selection and interview. In this case, and in other studies, it could be even longer. To implement this second deviation, we classified cases and controls by their cumulative duration of statin use after baseline, specifically treatment use for 5 or more years versus less than 5 years. And this was assessed through the time of selection for cases and through the time of selection plus 3 months for controls, that is the time of the interview. And then we adjusted for covariates that were measured at the time of selection instead of at baseline or later. And we did this by including them in our pooled logistic model. And for this last one, we actually were not able to implement this one to use pre-baseline statin use to quantify total duration of use because we did not have complete pre-baseline histories for some people in our cohort. But I still wanted to flag this one here as something that can happen if we lose sight of this underlying time zero. And so when we applied these deviations to our data, we also found implausible estimates that were similar to those previously reported, which was an odds ratio of 0.53. We estimated an odds ratio of 0.57. And so in this case, in our application, the key drivers of this bias appear to be the survival requirement to be included in the analysis, and the fact that treatment duration was assessed over a longer period for controls than for cases, where both of these decisions together depleted cases and enriched the controls for statin exposure. And we also found that what might be small shifts in absolute numbers can translate to big shifts on the relative scale. And this is important because relative measures of effect are generally all that we can obtain from case control studies, which therefore may be particularly susceptible to these biases. Other deviations in this particular case didn't make much of a difference, but in general, they may matter and lead to bias. We can talk about those some more in the discussion that follows if you're interested. But the bottom line is that all of these issues can be avoided with the target trial approach, which is going to just naturally lead to analyses that prevent these biases. And so to wrap up, I want to highlight a few key messages, starting with this one here. So in this example of statins and colorectal cancer, we saw that there was a wide discrepancy between evidence from previous observational studies and randomized trials, and that's a problem. But here, the problem with observational studies was not confounding. So we used the same observational data to do our analysis twice. When we followed the target trial approach, our findings were consistent with those from trials. When we deviated from that approach, we got a very biased answer. And yet there's critics of observational studies, some critics who even on this very same topic are quick to attribute these discrepancies to a lack of randomization in the observational studies. And so just to be clear, I agree that confounding is a very important concern that we need to consider in the context of a given causal question and a given data source. So for example, one consideration is, are we interested in studying unintended effects of a treatment? For example, are we interested in identifying repurposing potential for already approved medications, in which case confounding by indication may be less of a concern? Another consideration is, have we paired our well-defined research question with a suitable data source that contains adequate information on key confounders? So have they been measured well? Are they available for adjustment? And so this is just to say that the context-specific potential for confounding is a very important consideration, but in general, this focus, this overemphasis on confounding tends to overshadow considerations about what are major design flaws in some observational studies, which can lead to substantial bias and in cases can explain discrepancies between observational and randomized evidence. And these are entirely avoidable. These are the low-hanging fruit. And so my hope is that we can focus on resolving these first and see how far we can get in resolving these discrepancies. And then in the meantime, on the topic of confounding, continue a more nuanced discussion about the types of questions that we can answer in different sources of data. Another key message related to study design flaws leading to bias is that case control analyses are susceptible to all the same biases as cohort analyses. So why would anyone think otherwise? Well, because they seem so simple, right? We sample cases and controls and we compare their treatment status. At least this is how they're often framed. But this traditional framing can contribute to some common misconceptions about case control analyses. That is, that they are immune to many of the biases that affect cohort analyses, like time-varying confounding, selection bias due to loss to follow-up, and the inclusion of prevalent users, and that they do not require complete treatment and confounder history for cases and controls. And so these are both false. And we showed here in this application how flaws in case control analyses can be mapped to decisions in a cohort analysis that would lead to bias, especially on the multiplicative scale. And we also showed how explicitly emulating a target trial can help to minimize this bias, again, by anchoring the case control analysis to an underlying cohort study that explicitly emulates a target trial. And so if you're interested in causal inference and case control studies, I hope that you might consider this approach. And so with that, I just want to acknowledge my collaborators on this project. If you're interested to read more about our approach, I included our paper here. This is a QR code that you can scan if you have a smartphone camera, and that should link you directly to the paper. So thank you so much for your attention, and I look forward to any questions or comments.